Will we start, Dr. Lokesh?
Please go ahead.
Okay. All right. Yeah. Good evening, everyone. Thanks for again joining in. Today we'll be having Dr. Mankad, Dr. Atin Kumar from AIMS and Dr. Biju Hamid from Great Ormond Street as our guest panelists, and our regularly attended experts and panelists from all over India. We have 13 cases today, and we'll start off with our first case. Yeah, Pritija, you can go ahead.
Good evening, everyone. Our case is an 8-year-old male child who had a history of headache in the frontal area and vomiting for 3 days. And this child complained of similar illness 3 months back. There's also a history of gradual weight gain that had been noted since last 3 months. Ophthalmo evaluation was done outside, and it was suggestive of bilateral papillary edema. In view of headache, vomiting, and papillary edema, MRI brain was suggested.
Okay.
So we have the MRI scan.
Yeah, so these are the selected images of the abnormality in the MRI brain done on 20th October. As you can appreciate, there is a suprastellar cystic lesion extending up to the third ventricle, resulting in obstructive hydrocephalus. It is predominantly cystic on post-contrast study. Only there is peripheral enhancement. The cyst, one of the cysts demonstrates signal. The cysts are not demonstrating signal density of the CSF on the flare sequences. But as you can see on the post-contrast study, it's a predominantly cystic suprastellar lesion extending and into the third ventricle. At this point, the differentials were thought of was an adamantium craniopharyngioma and less likely an optic pathway glioma. Rituja, do you have the diagnosis?
Yes, sir. And this is a case of craniopharyngioma.
Okay.
Adenomatous craniopharyngioma.
Right. So after that?
So right frontotemporal craniotomy was done, and subtotal excision of supracellular tumor was done. And on the first post-operative day, child developed altered sensorium and visual field defect was noted. So CT scan brain was done on the first post-operative day.
And diabetes insipidus was present.
Yes, sir. And diabetes insipidus was noted. A child had polyuria. There was increase in the sodium level. Serum osmolality was increased and urinary osmolality was decreased. Endocrine consultation was done and management was done accordingly, sir.
Okay.
So in the CT scan, we want to ask what are the differentials for such kinds of lesion that is seen in the right frontal area, sir.
All right. So frontal craniotomy done. This is the site with expected postoperative changes, some degree of subgaleal collection over there. There is some degree of subdural collection, and the bilateral frontal lobes demonstrate edematous changes. There's a small focus of hemorrhagic signal changes on the right frontal region. Some mass effect on the frontal horn on the right side, as you can see over here, also extending up to the basifrontal region. In the cerebellum, there are patchy areas of hypodense changes in the bilateral cerebellar hemispheres and along the vermis. So that is the changes on the ECT. The changes are more evident on clearly demarcated on the MRI. So Rituja, the MRI was done.
Yes, sir. We again repeated the MRI on a 7th post-operative day in view of poor sensorium and persistence of visual field defects, and there was fever spike also present. So we repeated the MRI on 7th post-operative days.
Okay. So this is the MR 3 days after the CT scan, and we have the diffusion and ADC sequences. And now you can better appreciate the abnormalities on the CT. There are areas of cytotoxic brain injury involving the bilateral frontal lobes. On the right side is extending up to the anterior and mid portion of the basal ganglia. Small focus along the right posterior periventricular region. And the cerebellar abnormalities, again, you have multifocal patchy areas of restricted diffusion in the bilateral cerebral hemispheres and along the vermis. On the ADC sequences, there's almost complete reversal of the changes on the DWS sequences, except this area over here, which demonstrates vasogenic edema. On the ADC, the changes on the cerebellum were not demonstrating similar low signal changes as seen in the frontal lobes. T1 non-contrast sequences, again, you can appreciate the subgaleal collection, the post-operative site over there, some subdural collection, and in the right frontal lobe, bilateral frontal lobes, but more along the right side, demonstrating some degree of mass effect on the ipsilateral frontal lobe. Some areas of intraventricular hemorrhage on the SWI sequences. again, on the FLAIR sequences, you can appreciate the edematous changes in the bilateral frontal lobes and also in the bilateral cerebellar hemispheres. Another interesting finding which we found on the angiography was these focal outpouchings along the left posterior cerebral artery and the right precom. These are likely aneurysms or pseudoaneurysms, which are not visible on the MIP images, but the source images demonstrated these abnormalities. So the question was, Pritija?
Sir, how can we explain those cerebellar lesions in this child, sir?
Okay. Was the child having fever or infection after the surgery? Any?
Yes, sir. Child had fever spikes for few days after the surgery was present, sir.
Okay. So these are actually ischemic changes. I'm thinking probably secondary to the infection causing these areas of cerebral infarcts. The frontal lobe abnormalities I'm thinking of are secondary to infection and some degree of encephalitis, or there are some areas of thrombosis over there. So at this point, I'll open yeah.
Yes, so when MRI was done, the fever spike had already subsided, but when CT scan was done, there were spikes of fever present, sir.
Okay. And were there any seizures?
No seizures, sir.
Okay. But the changes are evident on the CT also. That was 3 days prior to the MR.
Yes, sir.
So as you can see, the hypotenuse edematous changes are there, which are better appreciated on the MR images. That the secret diffusion is around the subacute time frame. So that I would not, it wouldn't throw me away from the changes on the CT and the MR. So the question was, are these changes secondary to infection? Are these changes secondary to a mass effect caused by the subdural collection? And what is the reason for the possible pseudoaneurysms or aneurysms in the along the circle of Willis? So I'll open the case.
Can they also be related to any of the sodium metabolism disorders? Yeah. Although they are very tightly controlled, it was around 170, gradually brought down to 150 over a period of 5 to 7 days. No major fluctuations, but whether that's still a possibility, extra point-time analysis.
Dr. Athan, do you want to take up, any comments on the case?
Yeah, so I was thinking in terms of a ischemia only, right? So if we go to the MRA image, you were right, MRA. Dr. Nihaal, you said that there appears to be aneurysms, but even in the MIP images, I could see the right distal ICA appears to be slightly narrowed. And in fact, the proximal ACA and the proximal MC also. So maybe I don't know, this patient, because looking at the aneurysms or direct focal dilatations also, this patient probably would have an underlying vasculopathy and already had some compromised circulation. At the level of the surgery, there could have been during the surgery episodes of hypovolemia or which precipitated ischemia in the susceptible circulation, because
so that is exam 44.
We are using the steroids. Then another.
Because immediately on the day one post surgery, the patient had these symptoms, right? So I don't know what type of infection can occur immediate post surgery, which can precipitate such. There has to be something underlying which precipitated because of the surgical procedure at that time. That's my take on this, actually.
Got it.
And the SDH is not enough to explain the changes. That's changes, a very small SDH, actually.
So overall, infection-related changes, secondary changes, is that the conclusion? At least the parenchymal changes? Secondary ischemia to infection.
Not sure about. Actually, surgical, we spoke to surgeons later after we have seen this MR and CT.
Okay.
They said, I think the surgery and the retraction was only around anterior cerebral artery rather than any other areas. And I think there are some case reports about interleukin-6 containing fluid causing pseudoaneurysms in cases of craniopharyngioma, especially if it is cystic or adenomatous craniopharyngioma. So whether those posterior circular PCOM or PCA territory pseudoaneurysms are related to that, or any of these focal constrictions in the middle distal internal carotid artery are also related to that, we are not sure. Any comments upon that? I mean, as a result of interleukin-mediated injury secreted by tumor itself, causing vasculopathy.
That will be very unusual.
Very unusual because it was quite a huge tumor sitting around circle of Willis.
I mean, could it be because of hypernatremia and thrombosis and, increased thrombotic predisposition, and that's why you had some ischemic injury post-surgery?
But you have ischemia. If you're calling this ischemia, then it is there in the supra and infratentorial, and it's all over the place. That's a lot of ischemic injury to explain by just the ICA being narrowed, right?
Yeah, no, I was thinking microthrombi secondary to hypernatremia and diabetes insipidus.
Hypernatremia was an important discussion point. I'm just asking an open question as well. Given that you have some narrowing of the vessels, would you be thinking about RCVS as well in this particular case? First of all, tumors causing direct compression is very rare unless they have had radiotherapy and things like that. The surgery must have just entailed some kind of decompression, if I'm not mistaken. I don't know what the post-op scan looked like and how much tumor was removed. But given the irregularity of the blood vessels and the multifocal nature of this problem, should we not also be considering a reversible cerebral vasoconstriction syndrome, which may not be all that reversible anyways? And the extrapontine myelinolysis is an important thing to consider because it can manifest in different ways, but I don't know how quickly the sodium was corrected.
It was quite tightly managed, and we never dropped the sodium so quickly. It was very tightly. The fluid balance, especially for first 4 to 5 days, was very tightly managed.
So that would be unusual if it was so well managed, right?
Yeah.
Yeah, I'm thinking if you have to put the vasculopathy together with that, then we might be dealing with something else rather than direct ischemia and direct involvement of the vessel. In terms of Gauri's point about hypernatremia and diabetes causing microthrombi, is this microthrombic in nature? It's more than microthrombus, right?
Yeah.
Dr. Gauri Pasi has said moya-like changes after craniopharyngioma surgery is described in literature.
Not particularly surgeries, more with radiotherapy, and I don't think we have clear-cut moya here. And again, the posterior circulation involvement will be difficult to explain, right, in this case?
Yeah, and this was too quick. I think the changes are seen on CT scan day 1 post-op, day 2 post-op.
Yeah, I think it's too early for a moya.
So maybe the distal ICA was actually getting compressed by the tumor itself for a long period of time, and that led on to the stenosis which we are seeing.
It still won't explain the bilateral supra and infratentorial impact.
Doctor, I think these changes were not there in the pre-op scan, the cerebellar changes at least.
Right.
So something must have happened during surgery and
surgery itself. Right.
Post-surgery, something, I mean, the vessels must have been injured or vasoconstriction. I mean,
can the cerebellar changes be press?
If you're thinking press, you should think RCVS first, given the degree of vascular narrowing that you have.
And the frontal lobe changes, usually when you have a craniectomy, venous cortical vein thrombosis can cause something like a venous infarct like this one. So that could be the frontal lobe changes because it's the site of craniotomy. So RCVS with post-operative changes or changes due to surgery causing a venous thrombus and then parenchymal changes.
We can't exclude venous thrombus, but this will, if it is only venous thrombus, it's a lot of venous thrombosis everywhere. I would struggle to have a unifying diagnosis with just this. And in how many cases of surgery have we actually seen this kind of a venous infarction happening post-surgery? It is very close to the surgical bed. I can see that. But our surgeons won't like us if we give so many surgical complications as a diagnosis, I think. Clearly, they're not in the meeting.
Yeah. Because as far as we spoke to surgeons, the only artery which was retracted was anterior cerebral artery. And they said they were nowhere close to PCOM and PCA. And even MCA wasn't really handled.
One more thing, we are not sure the aneurysms were present before the surgery. We don't have an angiogram. So
Yeah.
it could have been present before the surgery. Only the parenchyma changes and the vessel narrowing may be post. And any handling of the vessel may cause spasm. This is known with aneurysm surgeries where they develop spasm after the surgery. So this arterial narrowing could be just a spasm related to surgery. Follow-up, I think, will show whether most of the spasm will resolve. The follow-up should show.
Thank you. I think overall, I think vasoconstriction syndrome is possible. The vascular changes are in the blood vessels are more likely pre-existing. Probably that's what we can end at this point of time. Thank you.
Okay. Thank you. So next case, Devangana.
Yes, sir. This is a 7-year-old female child. She had history of focal seizures, started at 6 months of age initially, and she had the second seizure at 3 years of age. The seizures were right focal motor seizures. EEG was done, but reports were not available. MRI was not done initially. She was started on sodium valproate, which was stopped 1 year back, and she was seizure-free for 1 year. She underwent intracardiac repair for double outlet right ventricle on 18th of October this year. And she was on heart-lung machine for a brief period. She had developed right heart failure following the surgical repair, which was treated conservatively with diuretics. 2-deco was suggestive of situs inversus totalis. On post-op day 6 on 24/10, she had one episode of right focal seizure, which was subsided with injection Lebepil. Then 3 days after, she had clusters of right focal motor seizures, that is twitching of the right side of the mouth, followed by jerking of right hands and legs, requiring 2 medications to subside the seizures. Then on 29, she had clusters of 3 seizures of similar semiology. Following on 2nd and 5th, she had started to have clusters of seizures.
Yeah, good. The MRI was done on which date? I mean,
MRI was done on day 12 of surgery, sir.
Okay. So that is before the seizure. I mean, I think few seizures.
Yes, after the seizure. Seizure started on 24th and MRI was done on 31st.
Okay. So initially we have a CT scan which was done on 29th October. On top is the non-contrast CT. There is some degree of volume loss in the frontoparietal regions. Some hypotense changes in the left frontal and parietal lobes. Some degree of volume loss in the cerebral hemispheres on both sides. No focal lesions on the post-contrast study. Cannot appreciate any post-abnormal meningeal enhancement. MRI done 2 days later. You can appreciate that there are some areas of cytotoxic edema involving primarily the cortical and some areas of the subcortical regions in the bilateral frontal parietal regions, the centrometal and the pulvinothalamic nuclei. There's a subdural over there along the right temporal and occipital region. The diffusion changes show reversal on the ADC sequences. FLAIR images, again, the edematous changes in the bilateral frontal lobes and the parietal lobes, predominantly involving the peripheral regions of the brain. These 2 focal areas involving the bilateral basal ganglia. Again, the subdural collection is appreciated on the right temporal and occipital region. This is a diffusion weighted sequence, no diffusion changes in the cerebellum, but there is a subdural collection over there. Angiography, no areas of focal stenosis or thrombosis. Venography again similarly demonstrates normal appearance. SWA sequence demonstrate multiple punctate foci of punctate hemorrhagic foci in the bilateral cerebral hemispheres involving the peripheral and the central regions of the brain, supra and infratemporal regions. The question was the Magna.
So there are two-stage injury. So what can possibly, what can be the etiology for that, sir? And
Why do you say two-stage?
Basically, we feel, I mean, there are two questions here. One, child had this prolonged cardiac surgery. It was quite a complex cardiac, this thing, and intracardiac repair was done. Was on heart-lung machine for quite a prolonged time, with some perfusion changes and all those things, which we are not aware actually. What we feel is there are some areas of restricted diffusion which are reversing on ADC, but similarly, there are few areas which are facilitating on ADC. So probably they are older changes or which might have happened around surgery. And the new cortical or predominant cortical based bifrontal areas of restricted diffusion, those could be because of status. That is what was our understanding and our theory. What we could not explain is, this child typically hasn't behaved like child who has had seizure following hypoxic injury to the brain. Continues to have very typical right focal motor seizures, starting with facial area, spreading onto hands and legs. So that's quite typical, showing that it probably is a injury. There is something in the left motor cortex, which is getting triggered because of surgery, which we have no clear understanding about. EEG was also showing very, multifocal discharges, but there were runs of focal discharges from left frontosentinel leads. So our questions are two questions. Two-stage injury, is it true or false? Second, is there an underlying focal structural abnormality in the left motor cortex? Which may, the left cortical abnormality may have been masked by these signal changes. Because the seizures are quite typically, characteristically right focal motor seizures, and they have a very typical progression as well. So that, in any other child, we would have thought of a structural underlying etiology.
Nihaal, can you go back to the story, please? And we are explaining the collection based on coagulation related issue, or how do we explain the right extraaxial collection, which is diffusion restricting as well?
She was on heart-lung machine for quite a prolonged time during complex repair. So that probably, I'm not sure whether that's very likely. That's the reason for the subdural collection, maybe.
It probably is, but it is quite restricting. Blood can restrict, but I hope you're not thinking that the child is also septic. Because there is, I think on that CT, I think it's with contrast, right? So it could still be hemorrhage itself because there are some areas of high density, but the whole thing is not hyperdense, you see. There's almost like a leptomeningeal enhancement going on as well. On the pre-contrasts, you don't really see a hyperdense hemorrhagic collection. And then when you look at the diffusion, you have a lot of diffusion restriction in that area. I'm thinking if this kid is septic, there is hypoxic ischemic injury, as you can see, but those medial thalamic changes and the patchy basal ganglia changes could be the driver here for the hypoxic ischemic injury rather than a secondary change. Nihaal, I don't know what your thoughts were on the extraaxial collection when you saw it, putting the CT and MR together. The microthrombi can be explained by the pre-existing cardiac problem that is expected in these cases.
There's some blooming of the subdural too. It's a subdural bleed, which is in subacute, early subacute phase, which is showing restricted diffusion.
Yeah, if it is very early subacute, we should still see it on the CT as a bit of a hyperdensity. You are struggling to see it on the CT scan altogether. And if that is
not sure.
Yeah, if that is a source of infection, it can be quite relevant. There are medial thalamic lesions, Gowrie, on both sides. Changes, yeah, all over that area, which is not the typical characteristic manifestation of ischemic injury in itself.
But I don't see any cortical structural abnormality though, Dr. Niket, if that's the question.
No, there is no cortical structural change.
Because
there is more change on the left side, and the frontal strip and the supplementary motor area are definitely more involved on the left.
Yeah.
It's understandable why the seizures might be. And then I have a question as to what explains the degree of background atrophy in the brain.
Cyanotic heart disease.
Yeah, Gowrie is thinking laterally here in terms of thymine. And in fact, when I saw those thalamic changes, I was thinking biotinidase as well. But I think it's a bit of a long shot given the storyline that we have with a pre-existing cardiac problem.
Because the only reason why we are asking about structural malformation is she had pre-morbid to this as well. She had seizures, which were also of a similar nature.
Yeah, at least on the MR which we had, I could not appreciate any structural abnormality.
Sure. And I mean, is there a way if that theory can be proven in follow-ups, or is there a clear need of follow-up scan to prove that, or can we actually prove it if we do a follow-up scan?
At least I don't think I need a follow-up scan for structural abnormality. If you want to see the resolution of the changes, then maybe yes. But,
yeah, I think later on we need to follow up, maybe after 6 months or 1 year.
Yeah.
Okay. Thank you.
So, Nihaal, can we just go back to CT?
Sure.
So, Dr. Kish, just one question. This hyperdensity on the plain CT, it looks like in the sinuses because the supraparietal sinus also appears hyperdense. Could it be related to polycythemia, which this patient probably would be having because of a underlying DORV for a long time?
She never had polycythemia actually.
She did not. Because
no, I mean probably she was iron deficient as well, but her hemoglobin wasn't too high.
Okay. Okay. Normally, DORV patients, I think because of chronic hypoxia, they do have polycythemia over a period of time. Right. But of course, this patient didn't have. Okay, fine.
Yeah.
Sure.
Okay. All right. Thanks. Next 3 sets of patients from Dr. Kamte. Dr. Kamte, if you're there, you can.
Yeah. Good evening. Am I audible?
Yeah.
Yeah.
Ashwin?
So this is a 7-year-old male child who was apparently normal till 2 months back and developed an episode of seizure, which was tearing for about 1 minute on alternate days, and it was followed by status epilepticus, but not associated with fever. A first MRI is there, which was done 1 month back. Then the child developed generalized seizures, which were this time associated with fever, with altered sensorium. The child developed 1 episode of bradycardia, which was told to us that they needed CPR, and following which the child was on mechanical ventilation for 1 week. Then the child was referred to us, and this time with gelastic seizures, with hypertension, and was noted to have a lot of oromotor dyskinesias with trunk thrusting movements and generalized dystonia involving all 4 limbs with oculogyric crisis. And then in our hospital, we had 2 MRIs done, which are with a gap of 20 days. So there are 3 MRIs of this child, which will follow.
Oh, okay. I had only 1 MRI sent. Any idea which one is this?
This is the 3rd, actually.
Okay. Anything on the first 2?
Actually,
okay, I think the 3rd should be fine. So diffusion and ADC sequences, there is some degree of high signal on the bilateral basal ganglia, which show a mixed pattern of reversal on the ADC sequences. As you can appreciate, there is a cerebral and cerebellar volume loss. Corresponding FAIR images, again, degree of volume loss is significant in the cerebral more than the cerebellar hemispheres. And you can appreciate periventricular hyperintensities, bilateral basal ganglia hyperintensities, hyperintensity on this cortical subcortical area on the right frontal lobe. Cerebellum in terms of lesions and signal changes appears to be normal. There is some degree of volume loss in the midbrain, corpus callosum on the sagittal images. So predominant central abnormalities in the form of T2 and FAIR hyperintensities with a background of cerebral and cerebellar volume loss. Some cortical subcortical abnormalities in the frontal lobe. Differentials on imaging thought of was autoimmune encephalitis. These are the antibodies involving the basal ganglia and the cortical regions. So NMDR encephalitis, anti-D2R antibody and MOGs could be a possibility. Viral infection, those less low down on the order. These are few viruses which involve the deep brain nuclei. And the other abnormalities, though they are more confluent and symmetrical of inborn errors of metabolism to be considered, but lesser down on the differentials. We are thinking of autoimmune first or para-infectious etiology. Ashwin, do you have any follow-up for the case?
So Nihaal, I just wanted to
good.
So the patient had a cardiac arrest and had a CPR. So basal ganglia changes and as well as the volume loss can be explained by the hypoxic changes because the patient had a definitive bradycardia requiring CPR.
Okay.
And followed by mechanical ventilation for a week. All this, I think, could be explained by the acute hypoxic changes at that time. The bilateral basal ganglia, along with the right frontal one, is also in the watershed zone. And we have this MRI which is done quite after
20,
that, right?
20 days later.
So even the global hypoxia can lead to even some atrophy also.
Okay.
Loss. That's my thought.
Okay. Got it.
That needs to be thought of.
Yeah.
Yeah.
So clinically, sorry, go ahead.
Yes, so we were getting to know the follow-up, how did the patient evolve after that?
Yeah, so this child actually initially we thought that might be having a mock encephalitis because the initial MRI which we did here, which was 20 days before this, was not showing so much of a cerebral atrophy. This has developed over the 20-day period. The white matter hyperintensities, they were there. But so initially the child's MOG antibodies were sent and thereafter even GFAP antibodies, but they were negative. However, after this second MRI and the persisting dystonia, the oromotor dyskinesias, then this child's evaluation was done further with NMDA receptor antibodies, which turned out to be positive for this child. So this is what we were feeling, that this is an abnormal, unusual MRI picture. And even the CSF, which was done initially, it was showing 32 cells with not raised proteins, normal proteins, only 32 cells were there.
The question is the NMDR encephalitis, the pattern of involvement in the brain is atypical or unusual.
Yes.
Am I right?
Yes, yes, sir.
Okay. But if I'm not mistaken, I think they do involve the basal ganglia and the cortical regions, though more commonly in the limbic lobes, but I'm not sure if it is that atypical. I'll open the case for the panelists.
So, sorry, did the first MR show basal ganglia changes? I presume we are looking at this one as a third MR, right?
Yeah.
So did the first MR also show basal ganglia changes or not?
There was a query of a subtle putaminal change, but that was not very clear. The first
so
MRI.
nothing on the diffusion.
No, we had the films with us. It was done outside.
Okay.
Yes.
Dr.
So these are
the first scan had shown changes in the putamen and the external capsule. The first scan. This was done before the child had a hypoxic episode, and then this child had happened. Then the baby came to us.
Any comments, Dr. Lokesh, Dr. Mankat, Dr. Biju?
Sorry, Nihaal, I had a
Yeah.
phone call come through, so I missed the first part. Going backwards, I think you have excluded the usual suspects here, right? But why is there so much gliosis in the frontal lobe? Particularly on the right side? You've lost gray matter as well, isn't it? And if you just went back to the history for a moment. And was NMDA excluded, for instance, in the background?
No, it's NMDA positive.
Oh, sorry, it is positive.
Yeah.
Okay, I missed that. So you found an MDA?
Yeah.
Okay. So that explains there must have been a viral prodrome, right, which has scarred off the brain in parts as well. And then it's triggered off the autoimmune process after that. Do we need to find more? What is the question?
Yeah, the question is the area of involvement, is it slightly atypical for NMDR encephalitis?
No, it's very typical.
Yeah.
The most typical, in 50% of cases, it'll be a normal scan, and then you have the bilateral basal ganglia, bilateral cerebellar or asymmetric involvement. The volume loss of the brain is also fairly typical in time. And then all these ill-defined periventricular white matter signal changes. I don't think you need to go down hunting anything else in this case.
Okay.
Sorry, I jumped in the middle. I did not see the first few slides or talk discussion.
That's all right. Dr. Kamte, anything to add upon or?
No, that's fine. Yeah, thank you.
Yeah. All right. Thank you.
I just had a question. Good evening, everyone. So are these changes really very typical of an MDR or?
Yes, they are. I think in the slide that Nihaal has shown, he's missed out one feature. Yeah, you got that picture there, but we've got examples if you want to add to your collection. But the bilateral,
NMDR,
and it's more bilateral anterior lentiform changes that we see. That's not published, of course, but if you see this case as well, it's almost got a gradient in the putaminal nuclei, for instance. The anterior bit is more than the posterior. But I think the clue is also in the earlier scarring of the brain in the bifrontal region. I don't know if you have hemosiderin staining there, or if this was a viral encephalitis or herpes kind of thing that had happened in the past.
Okay, sure. Thank you so much.
Yeah, next case, Ashwin, or?
Yes. Yes, so this is a 7-year-old female child born of a non-consanguineous parentage with 1.8 kg at birth. Mother had pregnancy-induced hypertension. This child started walking at 18 months of age, speaking by 3 years of age, and had seizures at 2 years of age and at 5 years of age. The child was suspected to have at that time hypoglycemic seizures, since the child had skipped meals and had also episodes of staring look, which were in early morning hours, and was diagnosed to have hypothyroidism at 5.5 years of age and was on thyroxine for the same. On examination, child was noted to have these hypo and hyperpigmented macules, which are like cafe au lait macules, and the hypopigmented macules, which can be seen on the limbs, and also had hypertelorism and hyperpigmentation at knuckles and toes. Child has also been operated for strabismus at 1 year of age. The MRI follows.
The skin changes are not along the blastal lines, right?
No, they are on the limbs.
Okay,
and they're not along the lines.
Okay. So the MR images, we have the T2s and the flare axils, multiple small, tiny T2s and flare hyperintense changes in the superficial subcortical and deep white matter involving the bilateral cerebral hemispheres, predominantly in the frontal lobes. Some prominence of the lateral ventricles, more along the trigones and the posterior aspects of the atria of lateral ventricles. Some degree of reduction in the posterior periventricular white matter volume, no structural abnormality on the T2s or the flare axial sequences, no lesions or volume loss in the cerebellum. No focal volume loss or gliosis in the bilateral cerebral hemispheres. Optic pathway structures demonstrate the normal appearance, at least on these images. The white matter changes did not demonstrate any areas of restricted diffusion, and on the SW also they did not demonstrate any mineralization or hemorrhagic components. Corpus callosum is slightly thinned, possibly dysplastic, but not very significant. Yeah, so multiple white matter changes. The question was, do they conform to torch, prior torch infection or tuberous sclerosis? I'm not sure if they are related to both, and I cannot make sure what the imaging findings are, if it's a neurocutaneous disorder, and how do they correlate. So I'll open the case for the panelists to comment upon.
And the history again, sorry. Yeah, so most of what we're seeing in the brain is actually the periventricular things, at least are very perivascular spaces, right?
Yeah, I'm not sure the slice thickness, but yeah, the flares, they don't suppress, but yeah, they can still be perivascular spaces.
Yeah, especially on the T2 that you're showing, and even on the flare, if you look at the periventricular ones, they look very typical for perivascular spaces.
Yeah.
And therefore, with the given situation of the skin picture, if you go back to the skin picture, usual exclusions, but I think you're probably heading towards some kind of a mosaicism rule out. You might not find a standard condition. By itself, the brain doesn't look like torch or tuberous sclerosis. And if it was only the brain and nothing else, no other history, then you would even entertain things like HLH and all that. But this is to be tied with the skin problem, I think, as best as possible. And I still believe that even though they're not saturating out on flare, they're most likely all enlarged perivascular spaces. Anyone with a dermatology interest should be able to describe that skin lesion better for us, isn't it?
Dr. Mahesh, is there scarring also in the skin, apart from the both hyper as well as hypopigmented lesions?
Yeah, there were some scars were there, but they appeared more post-inflammatory.
So they were not bullous?
No.
Okay.
The child had some knuckle pigmentation that we attributed to vitamin B12 deficiency. But this skin lesions and that MRI was like, how should we work up further now?
Was an MR angio done? Does this look like vasculitis?
MR angiogram wouldn't have helped even if you're thinking vasculitis.
Does this look like vasculitis? Could it be?
At least in the diffusion, some degree of cytotoxic, restriction would have been there. These are more like chronic changes or direct perivascular spaces, at least on the imaging. Nothing acute or early subacute abnormalities.
And no neonatal concerns, right, of larger skin lesions presenting with very acute little areas. Because if this was, what I'm kind of inkling towards, right, if this was a very early presentation with a large patch of hypomelanosis and all that, you would be entertaining diagnoses like ETO and all that.
Yeah, I thought of that, but the changes don't appear to be along the lines. I'm not sure if that's to be specific or sensitive.
Yeah. I think the answer will come from a skin biopsy.
Fine. We'll plan that.
But you have to exclude mosaics. You can't just get the standard gene panel. I think it's the NRAS, KRAS, and all those mutations become more relevant.
So Mahesh, how did you explain the hypoglycemic seizures?
No, like we thought probably it could be due to that low birth weight and all, but MRI did not show any obstructive glycosis actually.
No. So you have got two hormones involved, like hypoglycemic seizures and hypothyroidism, right?
Yeah.
So did you do a ACTH? Was it high, normal, with a hyperpigmented child?
No.
You should do ACTH because you have a child who's got hypothyroidism and who's got hypoglycemic seizures.
Okay, fine.
And there's a condition called STARS disease. So STARS acronym, hypoglycemia with the high ACTH, and so maybe you can check that, because I had one patient sort of similar with hypoglycemic seizures, girl, and who became really hyperpigmented because of high ACTH, and she had subtle dysmorphism.
Okay.
I'm not sure if she fits into this, but you can check. But
Fine,
I would
Vivek.
definitely do a ACTH.
Fine, we'll do that, and we'll admit her and probably get her early morning ECTH. Thank you.
Just on the chat, any developmental delay, Dr. Kamte? Head circumference?
Child had a small head.
Yeah,
Child has development delay.
there was-
Has development delay. Yeah.
Okay. Okay. All right. We'll move on to our next case.
Yeah.
This child is a 16-month-old male child born at term by LSCS with had cord around the neck, so had delayed cry at birth. No neonatal seizures, but the birth weight was 3.5 kg. Thereafter, this child was noted to have congenital nystagmus and as having left hemiparesis, reduced usage of the left hand, and attained neck holding at 10 months. Child is noticed to have a short neck, and for the hemiparesis, the MRI was done, and that is shown next.
Yeah. Any ocular abnormalities, Ashwin?
No,
Apraxia or something like that?
there is only nystagmus which is noted, which
Okay,
but
okay.
that yeah.
Yeah, got it. All right, we have the T2 axial sequences, and on the straight away on the axial frontal and parietal regions, you can appreciate that there is some areas of cortical malformation in the form of polymicrogyria involving the right frontal parietal regions, the perisylvian region over there. There are some areas of prominent perivascular spaces in the white matter, the periventricular deep and going up to the subcortical white matter. Coming down posteriorly, you can see that the vermis is dysplastic. There is elongation and thickening of the superior cerebellar peduncles, dysplastic vermis cerebellum. The posterior fossa findings are straightforward and suggestive of a molar tooth abnormality with polymicrogyria in the right cerebral hemispheres, at least on the T2 weighted sequences. On the chin cut T1 weighted sequences, you can appreciate on the coronals there is polymicrogyria involving the frontoparietal and perisylvian region on the right cerebral hemisphere. And also in the left perisylvian region, you can appreciate there is a polymicrogyria. The corpus callosum is slightly dysplastic. The brainstem is also dysmorphic. There's elongation of the midbrain. The ratios are abnormal. Again, you have changes of the horizontal orientation of the superior cerebral peduncles, molar tooth appearance, and again, changes of polymicrogyria more on the right cerebral hemisphere than the left. So the diagnosis is a Joubert syndrome related disorder. This is what we thought of. These are typical posterior fossa findings which are seen in our case. And polymicrogyria can be associated with the Joubert syndromes, and the genes which are listed there are the ones which have been described to be present with polymicrogyria. What was the question, Ashwin, regarding the case?
Yes, whether that right dysgyria is a known feature with Joubert syndrome.
Right, polymicrogyria rather than dysphagia, because
yeah, and it is bilateral, as you said.
Yeah.
It's got a very significant overlap.
So these are the genes which I found, commonly associated with polymicrogyria, and as you have seen that, though not commonly associated, but it can be seen in cases of Joubert syndrome related disorders.
I think you're obliged to do an entire ciliopathy panel here, isn't it? Of which there are around 40 or odd genes. So
yeah,
even things like I think AD, GR, G1, and
AD,
all this.
Yeah, GPR, the AD, GR, G1.
Yeah, the KIA, KIAA, and all that can give you an overlap. Thing is, this is also an overgrowth, right? The whole head looks big. This is a macrocrania situation, I thought. The cerebellum is big as well. Usually when you have just the rares by itself, you have small cerebellum and these molar tooths. When you look at the sagittal, the corpus callosum is thickened out there.
Yeah.
Things look a bit big.
Ashwin, head circumference?
The exact value I am not having with me right now. I'm not sure.
Dr. Kamte, anything to add?
Yeah, this child had a large head. It had a large head and a short neck. We are sent for a whole exome. We'll be updating in the next meeting. Yeah.
All right. All right. Thanks.
Thank you.
Thank you.
One finding here I wanted to show you all, which is unpublished, Nihaal, if you just go to the SAG, if you just focus your attention on the midbrain, the elongated dysplastic appearance of the midbrain on that fourth SAG, in the context of cortical malformations, I've seen it very commonly when there is a supratentorial involvement as well. Now we know that embryologically the midbrain actually develops with the supratentorium. It's not embryologically a part of the brainstem, and this is a good example to show that elongated appearance of the midbrain. This doesn't make the pons small. It's actually the midbrain that's a problem.
Yeah. Got it. Right. Thank you. Okay, to our next case from Dr. CG and Jen. Jen, if you're there, you can present the case.
Good evening, everybody. I'm presenting a case of 7-year-old boy was previously normal with no significant birth and developmental history and family history either. The patient had complaints of fever and rash since 4 days. Fever was undocumented and not associated with chills or rigors. The child also had a rash along with fever, which was involving the face predominantly, the distribution of a butterfly pattern, involving palms and soles as well, which was erythematous, scaly, exfoliating, and confluent with sparing of trunk. And there was involvement of oral mucosa as well with oral ulcers. And there was a possible history of joint pain since 1 week. And there was no history of any recent travel animal exposure to COVID infection or vaccination. Workup was positive for IgM dengue serology. And was the child being treated for the same?
Okay. And the skin lesions on the face?
Yes. So this is the facial rash which I'm trying to depict, which involved typically the forehead and the buccal mucosa, sparing of the nasolabial folds as well, along with the oral mucosa being involved, which is scaly and erythematous.
And also involves the upper chest, I guess.
Yes.
Yeah.
Yes.
Okay.
This is a rash which was on the soles and palms as well. So as the dengue workup was positive, we started treating the patient as the dengue patient with fluids and management. On day 4 of admission, this child had a seizure, so for which neuroimaging was done. So meanwhile, we started a workup for dengue and lupus as well. The CBC was unremarkable. DCT, ICT was negative. Renal function test, liver function test, electrolytes were normal, but ANA blot came back negative, came back positive, along with the immunofluorescence as well. So in the ANA blot, we had other antibodies also being positive. So the child had anti-RNP or Smith antibodies positive, along with anti-SSA positive. And the immunofluorescence was also strongly positive. So with this, we kept our diagnosis as lupus along with dengue. And the child was planned for MRI as the child had seizure on day 4.
And there was no hypertension or?
Yes, sir. In the beginning, the child did not have any hypertension, but after the seizure, when the child had raised ICT, the child developed hypertension later on.
So this is after the scan or before the scan?
So after the scan, sir. The child had hypertensive readings after the scan. So other workup, we have started working up for SLE, multi-organ involvement. Coagulation profile was normal. Urinary protein creatinine ratio, there was proteinuria, which was suggestive of nephritic nature, again favoring lupus. And the child was started on steroids accordingly.
Right. So we'll look at the images first and then get back to the discussion. Yeah, so we have the MR sequences, and you can appreciate that there is a large intraparenchymal hemorrhage predominantly involving the right to basically ganglia of the capsular region, causing compression on the ipsilateral lateral ventricle with some intraventricular hemorrhage. Some ischemic changes or hemorrhagic changes in the left periventricular region over there. But the predominant finding is this large right basal ganglia capsular hemorrhage with intraventricular hemorrhage in the lateral ventricles, causing some degree of obstruction and some lateral ventricularly. Angio was done. I don't find any abnormalities. There's a focal defect over there, but possibly I don't have the source images to confirm if that's a narrowing or not. Again, on CT images, the findings on the MR are evident. Large intraparenchymal hemorrhage. Typically, the type of hemorrhage is of a hypertensive bleed, but I'm not sure if the child was checked for hypertension prior to the MR and the CT. So this is the follow-up.
The child was started
Yeah.
on high-dose steroids and azathioprine and hydroxychloroquine in view of lupus. A nephrology consult was taken as the child had hypertensive readings after the seizure, that is, after the imaging was done. And surgical evacuation was planned, but the parents did not consent for. So we have only medical management which was done, and anti-edema measures were taken. So I just wanted to ask you, what could be the possible cause of the bleed? I mean, there was no setting of coagulopathy or a low platelet count in this child.
Yeah, so these are the typical imaging findings which see in lupus, ischemia, microhemorrhages, demyelination, press, myelopathy. Macrohemorrhages are seen, but they are pretty rare unless there are secondary complications such as hypertension or coagulopathies. Some reviews have described intraparenchymal hemorrhage in changes of patients with lupus. Again, the area of the location is typically what we see in a hypertensive child or adult. So I'm not sure if that corroborates or if the PP was checked before the scan or not. Dengue also is known to cause intraparenchymal hemorrhage, but more microhemorrhage than the macrohemorrhage, and they usually have thalamic lesions rather than a unilateral involvement. But yeah, I'll open the case for the panelists to add their comments on.
So this is a mixture of vasculitis and hemorrhagic press that you're seeing here in the context of the positive antibodies that you have. I have no other differentials for this.
Can we have?
Yeah.
Sorry. Can we have a normal MR angio if we suspect a vasculitis here?
Very commonly.
Very commonly.
Okay.
Yeah.
Okay.
Because we're looking at.
So actually, it is not entirely normal because that little dent is not clear as to what it represents. And MR angiogram, first of all, is the wrong test for vasculitis screening. But if you start looking closely, look at the distal MCA on the right side. It's got caliber changes happening now, but this is a flow-related phenomenon that you're seeing, so we can't be very clear and judgmental on this. I think it's just the wrong test, and it's a good example to show that.
Okay. So what further, what should we have done for this child? Because the parents were not willing for further investigations or management.
Personally, I believe a CT angiogram would have been better because the CT was already done to look at the blood vessels, but you would still be encountering vasospasm on the right side, given that there is so much hemorrhage. The second thing is you might be wanting to look at evidence of vascular problems elsewhere in the body, like Dopplers in the renal arteries and things like that. I believe, and we don't do it even in this center, if you're doing MR only, then probably contrast-enhanced MRA might be better, but it's not an easy thing to do. But MR angiogram we all do, and we hope to see things. We never really see it in the context of proven vasculitis as well.
Okay. Okay. Thank you.
Okay, right. Thank you. Next case, Sahil.
Yes, sir. She's a 8-year-old female with normal perinatal and developmental history. She presented to us with history of headache since 2 days, and followed by she had a vomiting, and post which she became completely unresponsive. And on admission, her GCS was 7/15. Pupils were bilaterally equal, reacting to light. Tone was normal. Reflexes were brisk. So initially, she was rushed to the emergency, followed by a CT scan was done, followed by an MRI. So we'll discuss the scan first. And
okay. Yeah. Clinically, what are you thinking? Anything? Infection, encephalopathy.
Acute, yes, sir. Acute encephalopathy. She didn't have febrile fever episode.
Okay, so just acute encephalopathy. All right. So we have the CTs on 16th October. There is effacement of the sulcation pattern in the cerebral and cerebellar hemisphere, more in the posterior fossa, some degree of lateral ventriculomegaly with periventricular oozing over there along the occipital horn. There is effacement of the cisterns along the brainstem, and you can see that some herniation of the tonsils below the McRae line, some acquired tonsillar herniation going on there. So supratemporal ventriculomegaly with some periventricular transependymal edema, cerebellar edema possibly, and some cerebral edema, though an MR would be more appropriate for this. So 2 days later, an MR was done. You can appreciate that there again, the periventricular edema is there in the lateral ventricles, though now the VP shunt is spaced, so the ventricles have come down in size. The primary changes are in the cerebellum, demonstrating these edematous changes on the flare sequences. I did not have a diffusion weighted sequence to check if there is restriction or not. But yeah, predominant cerebellar edematous changes, possible cortical abnormalities on the flare, but I was not very sure of that. On the T2s, again, posterior fossa demonstrates this edematous changes, effacement of the cisterns, again, narrowing of the cervicomedullary junction, some mass effect on the fourth ventricle and the dorsal aspect of the brainstem. Again, transrectopia down there. Post-contrast study, there is leptomeningeal enhancement along the bilateral cerebellar hemispheres, no supratentorial enhancement or abnormality, no cisternal enhancement. Yes, so at this point, you got another
Yes.
CT done.
So, yes, sir. So followed by which the child was intubated and it was shifted to PICU, and in view of the ventricular megaly, the Omeya reservoir was being a neurosurgery call followed by an Omeya reservoir, and a CSF panel for nasopharyngeal swab and CSF was sent, which showed 14 cells with the protein of 69 and glucose of 78. And viral panel was sent, CSA viral panel, which was completely negative for H. influenzae, streptococcus, HSV 1 and 2, and CSF PCR, and CSF pneumonia was also sent. And for other respiratory viruses, even COVID was also done, which was also negative. So considering the fact that this child had improvement in clinical, after which the possibility of autoimmune cerebralitis was being kept forward, and then she received a methylprednisolone for 5 days pulse dose, and after which there was improvement in her consciousness, and her consciousness improved. Clinical also she improved, and repeated scan was done on 20th and 24th. The first CT scan was done followed by an MRI.
Yeah, so this is the last MR. So the pressure changes on the posterior fossa have improved. Again, you can appreciate the CSS spaces along the posterior fossa better than the first scan, but still you have the edematous changes in the bilateral cerebellar hemispheres. Fourth ventricle is much better appreciated than the first scan. So the reservoir and the VP shunt have worked well for this child. So based on the imaging findings, thinking of cerebralitis, infectious, para-infectious, that was my first thought, rather than an autoimmune disorder, given the acute onset and significant edematous changes resulting in obstruction of the ventricles. I think autoimmune might take, I'm not sure if it's right or wrong, but it's over a longer period of course. Okay, sorry.
It's not autoimmune, it was post-infectious, yeah. Immune-mediated post-infectious.
Okay, got it. All right. Yeah, so cerebralitis was the imaging finding, at least. Whether it is infectious, post-infectious, that I think labs would be more helpful. I'll open the case for the panelists.
So I just wanted to ask, in this situation, retrospectively putting a Omeya saved the child, but ideally this should always be accompanied by a craniectomy, because you were lucky. This child would have had a reverse herniation just by putting a supratentorial drainage. So, and my question, so should one in this situation with this MRI do a craniectomy with a supratentorial drainage or just a supratentorial? Because if you just do a supratentorial drainage with a cerebellum in pressure, it will go up. So you were lucky.
Yeah, so our neurosurgeons actually were debating between the two, and they first of all decided to just put an Omeya. The child was quite unstable, and so they thought that first putting in Omeya, and later if needed we'll do a craniectomy.
It should be the other way around. First craniectomy, then Omeya.
So they
because
were
if you do
debating for
then
a while.
cerebellum goes back and the fluid starts to drain.
Yeah. So there was a debate among them also on the same thing. In fact, I was surprised why they chose Omeya over craniectomy, because straight away we should have done a craniectomy.
I had one question. This child presented with acute onset headache and sudden loss of consciousness, which sounds like a subarachnoid hemorrhage. Did the first CT have evidence of subarachnoid hemorrhage? Could you go to that?
No, Dr. Gauri. I cannot
Actually,
find any.
raised ICP, I mean, very acute. In fact, one of the presentations is like this only. Because of the acute hydrocephalus, they can have just encephalopathy. Very severe raised ICP leading to acute encephalopathy.
So
And it
he
can
had
be
no
very
fever.
fast.
He had no fever. He just had headache and sudden loss of consciousness. It was very acute, isn't it?
Yeah.
Just
Vomitings and all was there. I think
headache?
just for
No
1 or
fever.
2 days, the child was symptomatic. Headache and
Okay.
vomitings.
And subarachnoid can be missed on CT also. Could this explain?
But it would have been picked up on the MR, at least from the SWA sequences, which I could not find any subarachnoid hemorrhage there.
Nihaal, we have a picture of global encephalitis here, right? With the cerebellar over.
Yeah.
So we have to, and in terms of etiologies, I'm thinking viral encephalitis first. And we should be thinking about influenza, parainfluenza, mycoplasma, along with other things.
So actually, we didn't do mycoplasma, but our CSF biofiles actually covers a lot of these all viruses, otherwise respiratory and all, as well as these common bacteria. But mycoplasma, I didn't say.
Enterovirus.
Yeah, it is all there in that
Okay,
biofiles panel. All the common viruses which cause
sir,
encephalitis and but mycoplasma has to be sent separately, and it is a PCR which is not easily available to send to us and very costly. Yeah.
Okay. If there are no further comments, we'll move on to the next case.
Yeah, but I just want to share
Sorry.
that we had a previous child like this, I think many years back, and that child actually improved initially on, so he did not have such florid bilateral cerebellar lesions, and he also had cerebellitis. And as Vivek said, the craniectomy should be really considered early, and I totally agree with him. And that child actually, again, the same thing had happened because he improved. He was extubated, shifted out to the step down unit. And in the step down unit, next day he collapsed. He just went into coning and he developed very severe post coning, all the basal ganglia and everything changes. So these actually children are really dicey and need to be. This child is really lucky to have come out. Now is on tapering dose of steroids, but. Will you use steroids here? I mean, I just want to ask other this thing. Though viral would be our first possibility, but always at the back of our mind, post-infectious is there, and steroids can also reduce the edema very rapidly. So, will you use steroids in all these cases, or wait for the response, and then what is the strategy that everybody else does? Mahesh, Vivek, Lokesh.
I would always use steroid, always. I won't bother about the viral infection. That's more
I
of a
think
weird
steroids.
Okay.
Yeah.
Thanks. Okay.
Agree. Yeah, and posterior fossa decompression. Similar thing can happen with posterior circulation strokes with cerebellar infarcts, where I think posterior fossa decompression is a life-saving thing.
Yeah, agreed. Totally agree. I was in fact debating with the neurosurgeon that we need a craniectomy. But I think with all that intubation and everything, they were just very comfortable putting in Omaya first. Okay, thank you so much.
All right, thank you. Dr. Rashmi or Archana, if you want to present the case.
Dr. Archana here. So we have a 4-year, 10-month-old female child who came to us primarily for complaints of hematemesis and melena. But she also had complaints of headache and vomiting, which was going on for 3 months on and off. The headache was getting relieved by vomiting, and she was on ibuprofen for the same. She eventually underwent endoscopy and we found out to have gastric erosions, but she has a past history of having extensive mongoloid spots and nevi all over the body, including face, trunk, and limbs with scleral hyperpigmentation. She was also noticed to have capillary hemangiomas involving face, neck, and soles. And she also had mild leg length discrepancy and mild hypertrophy of the right lower limb. So these were the findings at birth and thereon. So these were the capillary hemangiomas and the extensive nevi and mongoloid spots, which was noticed. She had she was diagnosed to have phacomatous pigmentovascularis type 2, and whole exome sequencing was done on a skin biopsy previously. That showed a mutation of GNA11. And because she persistently complained of headache and vomiting, we did an MRI brain with contrast angiography and venography. On the same MRI findings will be discussed. On the same day of MRI, she also had a seizure, and she had further deterioration in her vision. And she persistently complained of headache and 1 to 2 episodes of vomiting post that too. Can we have the MRI images?
Yeah. Dr. Savit, you want to go ahead with the MR?
What we see on the T2-weighted images is there is subcortical T2 hypointensity. Both this is also seen on the flare. There is asymmetry between the occipital lobes. The right side appears smaller as compared to the left. There is no corresponding diffusion changes. Should we go to the next slide? Yeah. Now, when we look at the SWA, there are prominent perimedullary veins which are seen extending from the cortical surface all the way down to the periventricular region, mainly or predominantly in only the left cerebral hemisphere. The globe length appears normal. It is not oblong, or there is no bulge or anything. Now, here, if you closely see, there are some prominent vessels which are seen along the dura in the left on the left side. The next slide, please. Yeah, those. Okay. Angiogram. So this is a TOF angiogram and this is a contrast angiogram. Now, when we see the TOF angiogram, there is an asymmetry between the right and left ICA. And what we see is there's a focal narrowing, which is there in the distal cervical ICA on both sides, more prominent on the right side. Now, when we see this dynamic contrast angiogram, there is a delayed filling. Now, TOF shows a flow signal on the right side, but in the initial arterial phase, the ICA is not seen. So it says that there is a stenosis in the distal cervical ICA bilaterally, right more than the left. It's a focal stenosis, probably a dysplastic segment of the ICA. The intracranial circulation grossly looks normal. Now, on coming to the venous, there's a variant. We have a marginal sinus which is draining to the sigmoid sinus. The transverse sinus are hypoplastic. When we look at the ASL, we see there is hyperperfusion which is there in the left frontal lobe. The next slide, please. Okay, the post-contrast scan, there is extensive leptomeningeal enhancement in the left cerebral hemisphere, predominantly the temporo-occipito-parietal region, both on the T1 and the post-contrast flare images. And also what we see is chorioretinal enhancement only in the left globe. The imaging features are suggestive of an Stroop-Weber's. What we have is a extensive leptomeningeal enhancement, chorioretinal enhancement. The only odd is the atrophy of the brain is on the contralateral side, and an associated this subcortical T2 hypointensity, subcortical T2 and flare hypointensity could be probably due to venous congestion because of extensive venous changes, venous abnormalities in that hemisphere, or it could be a ictal, post-ictal or post-intrictal or seizure related. And there is an associated finding of dysplastic distal cervical ICA bilaterally, right more than left. So the imaging features are suggestive of a Stroop-Weber's. Now, with PPV, among many associations, Stroop-Weber's is also one of the associations. So
this
is
are examples PPV? Of PPV with Stroop-Weber's. Yeah, over here. Because both involve the GNA11 and GNAQ genes. Is that right, Dr. Savit?
Yeah, true.
Yeah.
So Sturge-Weber's is among so many associations. PPV can also have, when some of them have already been discussed. The child has a hypertrophic limb. They are also known to have colonic polyposis, and a lot of associations have been seen. One of them is this Sturge-Weber's. And Sturge-Weber's is the commoner association.
So the child has been started on levetiracetam, and the plan is to start on aspirin once gastric erosions resolve. Optal examination was done, but the child was known to have pathological myopia with a rapid increase in power from -5 to almost -8 in last 3 months. There were no features of glaucoma, oral report. And but the issues are the child continues to have headaches, short duration seizures, photophobia, and diminution of vision.
Okay. So the
The unusual thing about Sturge-Weber here is the arteriopathy that you have with it, right?
Yeah.
I have Googled this, Nihaal, but if you guys have, I don't think this association has been described.
Sir, the association here is with PPV. So PPV, among many associations, probably this must be an associated, arteriopathy may be an association with PPV.
What PPV means, what does PPV stand for the benefit of everyone?
Phacomatous pigmentus vascularis.
Okay, but in that situation, is the arteriopathy commoner compared to the Sturge-Weber syndrome, or?
Sturge-Weber's is commoner. Sturge-Weber's is commoner.
Yes, Sturge-Weber is, but what about the arteriopathy?
No, arteriopathy is an association, but it's a rarer association.
But have you, what is the level of evidence you have? Have you seen case reports on this?
Yeah, case reports.
Okay, see if you can share any with me, because I haven't checked it on PubMed or anything, but if you have, that's useful. But it's still unusual for the benefit of the audience. It is a very venous and a capillary venous phenomenon, what you get in SWS. Did the patient have a port wine stain?
The child had capillary hemangiomas on face, neck, and soul, sir.
So not a port wine stain?
No, not now.
Okay, that's usual with the Sturge-Weber. So it's actually a different spectrum, I think we are seeing compared to the standard Sturge-Weber, right?
The child had genetic testing on the skin biopsy, and they had come up with 4 mutations. And we looked into all the 4 mutations, and among them, the GNA11 has an association of this phacomatosis PPV with Sturge-Weber syndrome.
Yes, the GNAX and the GNA11. I think it's a great case. You should publish this, by the way.
Yeah. So the headaches are now better, but looking back, I thought those headaches with vomiting episodes was possibly occipital lobe seizures, because on EEG, there are slow waves in the bilateral occipital region. The child had another seizure and is now on 2 medications, levetiracetam and valproate, but no further seizures since then. And the headaches have also now resolved with the new glasses, because the myopia had increased, and with that, now the child is not having any headaches. Someone's asked, what is blood pressure? Blood pressure is normal.
We can also consider sirolimus, which works quite well to prevent this kind of episodic encephalopathy, seizures, high blood pressure, which can happen with Sturge-Weber. Only thing is, we have not used with somebody with narrowing of the arteries, large arteries. So we need to just check the safety in that sort of situation.
I had a question in this case. Why is there usually Sturge-Weber's will be associated with atrophy on the same side, but we have the atrophy of the brain on the opposite side? Do we have an explanation? I only thought that because there's an asymmetry in the intracranial, cervical ICA, and right ICA is smaller than the left, probably that must be the cause for the atrophy on the right side. Any thoughts on this?
I think
Yeah.
that's the explanation.
But is it real atrophy?
It looks asymmetrical.
I think it has been scanned asymmetrically. The patient is looking towards one side for some reason. Everything is a bit looking towards the right side, isn't it?
No. I think the finding is real. It is not artifactual because of the scan plane.
But where are you describing the atrophy? The whole hemisphere might be small.
No. Only the occipital lobe. If you look at the occipital lobe on the right side, it is definitely smaller than the left.
Is it now? What is more important is that the white matter signal is different on the two sides. And I think that's to do with the PL angioma on the left.
Right.
Yeah, that's the white matter volume is also smaller on the right side, lesser on the right side, white matter volume.
I think the whole right hemisphere, if you're calling, might be small, because on that picture, the first one, at least, even the caudate looks small on the right compared to the left.
Someone's mentioned the left occipital lobe could be edematous. Julia has mentioned left occipital.
Edematous, not really, because there is no edema. What we are seeing in the white matter and the T2 is actually accelerated myelination in the context of what happens with PL angiomatosis. But in terms of the hemispheric difference, of course, you can quantify the volumes, but if you were to call the right side small, I think the entire right side might be small. That's why it looks a bit small, because the ventricles are not really asymmetric, but look at the caudate on the right. And then it could be due to the vascular supply itself and the problem with the ICA that you have. One question, was the skin manifestation directly overlying the left side, or where is the skin problem here?
So the pigmented nevi were there bilaterally. It was there all over the face, on the trunk, both the limbs, and even the lower limbs. So it was bilateral.
Yeah, so we shouldn't actually use the word Sturge-Weber syndrome for this case at all, I think, in this case. This is completely a different spectrum. Neurocutaneous, yes. I mean, it depends on how you define Sturge-Weber syndrome, but that itself is different between countries.
Sturge-Weber syndrome, based on the manifestations, there are type 1, type 2, and type 3. But type 3 will have only leptomeningeal angiomatosis only, no skin manifestation. Can this be the type 3 one?
Yeah, if at all, it'll be a type 3. And you've got a mutation driver which is known to be associated. But the PPV is more important here than SWS, I think.
Yeah, that's true.
Dr. Saved, can you just explain to us what ASL is and how it will help us? Because we don't see these images routinely. So
ASL is an non-contrast perfusion image. It's called as arterial spin labeling. So what we do here is we tag the blood vessels which go to the brain at the level of the neck and acquire the images when these tagged blood vessels reach the capillary phase. So whenever there is an hyperperfusion where these tagged blood vessels reach faster, they produce an increased signal. So likewise, when we see an increased signal in this case, it means that area is hyperperfused. It can happen in any condition, like if you have a seizure in that region, which is causing an increased blood supply to that region, which will show an elevated perfusion. Whenever a region has low perfusion, like if you have a stenotic segment, you have a stenotic vessel or in an infarct where there is no perfusion, that area will look blue. So this is the scale, the color scale. So hypoperfused area and hyperperfused area, it all determines the rate or the speed in which these tagged blood vessels reach the site. So we use this mainly for stroke, but any CNS pathology, be it headache, be it seizures, or be it arteriovenous malformation, or anything, we use it, because in a stroke it helps us to quantify the perfusion defect, that is the infarcted brain. In seizure, if it shows an elevated perfusion, it helps us to identify the focus of seizure, or that is mainly in the ictal and interictal phase. In the delayed, sometimes in the post-ictal phase, the epileptic focus, seizure focus may appear hypoperfused. In vascular malformations, especially when you have a dural arteriovenous fistula, we see venous ASL signal. That is which again is an imaging. This helps us to pick up a dural arteriovenous fistula before we, which we can be suspicious of, and then do an angiogram to confirm it. That is a digital subtraction angiogram. So any like headache, like someone who has a migraine. So if there is someone who is in a vasoconstrictor phase of the migraine, then it will show a occipital lobe hypoperfusion. Or someone is in a phase where he presents with migraine with aura, it will show an hyperperfused occipital lobe. So in that way, we use this. It's more like a functional imaging of the brain without using the contrast.
Okay, thank you. Thanks for that.
All right, thank you. We'll move on to our next case. Yeah, Dr. Yoda.
Hello, yeah. Good evening, everyone. My patient is a 8-year, 7-month-old child presented with the history of deviation of mouth to the left side on 3rd of September 2022 and complaints of unable to write on 7th of September, which is on the 4th, next 4 days later. Child also had complaints since the past 13 days. Like the details are deviation of the mouth to the left side for about 10 seconds with slurring of speech and palpitations noted by the father on 3rd September, following which there was spontaneous recovery and there were no visual symptoms associated noted. And child was unable to write due to tremors and the memory impairment on the 7th of September. Following 30 minutes, child was all right. Also, there was complaints of cough since past 13 days, which was dry type, not associated with blood or sputum, no postural or diurnal variation or no special characters. And on the birth history, it was an extreme preterm baby, 30 weeks, 1.7 kg, low birth weight, cried immediately after birth and had an ICU admission for about 10 days. Developmentally, he was up to the age. Examination vitals were temperature was normal, 98.9 degree Fahrenheit, pulses were 120 per minute, saturations 98% at room air, respiratory rate of 30 per minute, weight of 27.4 kgs. Like the 4 limb BPs were, in the right upper limb, it was 89/58. Left lower limb, it was 108/61 millimeters of mercury. Right lower limb, it was 104/75, as it was documented on 12th of September. CNS examination was within normal limits. Further course during the hospital, child was investigated and the blood investigation showed like high CRP of 42, ESR of around 20, hemoglobin was 8.3 milligram per deciliters, WBC counts of 7,660, platelet 2.49, and albumin globulins were 3 and 4.9 grams per deciliter. Further, ANA profile was done, which was full profile was done, which was negative, except for the lupus anticoagulant, which was a little on the positive side. And the MRI was done on the 10th of September, which was on the 3rd day of after the 2 episodes.
Yeah, Dr. Samit, you can go ahead.
Yeah. So on the diffusion weighted images, we see cytotoxic edema, which is predominantly involving the left MCA territory, the frontal operculum and the frontal lobe. There are corresponding changes on the flare. We see hyperperfusion in this area corresponding to the site of infarct. So this hyperperfusion probably suggests that it's an area of luxury perfusion. When we look at the SWI images, we see susceptibility signal, which is there in the region of the insula, which probably represents, which is along the course of the vessel. So probably these represent thrombi within the occluded vessel. On an angiogram, we see paucity of the MCA branches on the left side. Paucity of the MCA branches on the left side. So when we correlate both, it probably says that there are small thrombi in the distal M2 MCA branches causing occlusion. The rest of the MCA branches are filling or patent. So this is an angiogram image, contrast angiogram. Now, if you look at the aortic arch, in the region of the descending or in the region of the isthmus, you see a narrowing here. There is a change in caliber of the aorta. So if the innominate artery is normal, there is a stenosis which is involving the right subclavian artery. This is the vertebral artery. It looks normal. When we look at trace the common carotid artery on the right side, it is diffusely narrowed. And from the region of the carotid bulb, we see a good caliber internal carotid artery. Now, there is a small stump seen, which is the site of origin of the left common carotid artery. The rest of the common carotid artery is not visualized. Then we see the carotid bulb and then the ICA, which is of normal caliber. The vertebral artery is of normal caliber. We see a stenosis, which is involving the origin of the left subclavian artery. This is the image which is showing the stenosis, which is in narrowing of the descending thoracic aorta. Okay. The child presented with stroke, so we did vessel wall imaging of the neck and the intracranial arteries to look for any vessel wall enhancement. Now, when we look at this is the images, the vessel wall imaging of the intracranial arteries were normal. There were no vessel wall enhancement seen in the intracranial arteries. Now, when we come to the arteries of the neck, the aortic arch, we see there is thickening, which is seen around the aortic arch with enhancement. When we ascend up, see, this is the common carotid artery, which is showing circumferential wall thickening. The left side common carotid artery is occluded, so that's why we don't see any flow void, but we still do see circumferential wall thickening. Now we go ascend up. The right side is artery is still patent, common carotid artery. It shows wall thickening. The left side is occluded. So that this is the comparative vertebral arteries, which show a normal flow void without wall enhancement. This is the just proximal to the region of the carotid bulb. Patent lumen with a circumferential wall thickening with enhancement. This is at the level of the internal carotid artery. We see a normal internal carotid artery, normal flow void, normal vertebral flow void. This is the carotid bulb region, which we still don't see a flow void, but see a wall enhancement. So saying that there is wall enhancement involving bilateral common carotid arteries, the left common carotid artery is occluded, the right one is patent, and there's also enhancement in the aortic arch and the origin of the aortic arch branches. This is a corresponding CT images showing circumferential wall thickening involving the descending thoracic aorta, the aortic arch, the aortic arch branches, and the region of the ascending thoracic aorta. So this is subclavian, this is the common carotid, and this is the innominate. So the imaging findings suggest that it is an aortoarteritis, which is mainly involving, we have only imaged the aortic arch branches, so it's mainly involving the aortic arch, the ascending arch, and the descending aorta and its branches up to the level of the carotid bulb. The intracranial arteries and the internal carotid arteries and vertebral arteries are normal. There's no vessel wall enhancement which is seen in the intracranial arteries. What we see is infarct in the left cerebral hemisphere with occluded MCA branches, so probably suggesting that a thrombi which is occluding these vessels and a resultant infarct. So in a child, the pattern of distribution of these arterial changes would suggest it could be a Takayasu arteritis.
So the further course was child was regularly monitored for his hemodynamics and blood pressures in the hospital. Dr. Chandrika Bhatt, pediatric rheumatologist opinion was taken, and the child was started on methylprednisolone pulse therapy. Child was also started on MMF and the aspirin, and it was discharged on the tapering doses of prednisolone tablet, mycophenolate mofetil, and aspirin and other supplements. And there was a plan MRI after 6 months, which is
Dr. Rashmi?
Yes, yeah. So this child just presented, as you know, with a transient ischemic attack. And when they examined the child, found a systolic murmurs, which is quite uncommon. So that's why we refer to the cardiologist. And the cardiologist picked up on this possible Takayasu arteritis, started the child on aspirin, and then referred to me. So though you've seen the stroke on the MRI, there is no neurological deficit at all. The neurological examination of the child is completely normal. So like Dr. Vivida has said, we have told the parents, we started all the immunomodulators as per the rheumatologist, and we plan to repeat the MRI brain to look for any resolution or anything like that in the next 6 months, unless the panelists feel anything different, anybody's had a similar patient and all that.
From an imaging perspective, that's, I think, the correct timeline.
Okay.
Diagnosis is quite obvious here, right?
Thank you.
Okay, thank you. Dr. Prerna isn't there, so we'll skip to our next case. Dr. Padma, if you're there.
She had cerebral atrophy.
No, she wanted to present it for the next meeting, so we'll do it next time. Yeah, cerebral atrophy with ataxia, telangiectasia. Yeah, Dr. Padma, go ahead.
Yeah, this was a 17-year-old previously well child who actually came with a headache since 3 months, which was gradually worsening and vomiting since the last 3 days. She came with 2 episodes of seizures on the day of admission. The last one was a status, and she had already received midazolam, levetiracetam. And when she came to us, she had a GCS of 13/15. She was otherwise neurologically, there was no focal deficits except for bilateral papilledema. She was a well-built child with, on probing, there was some history of a low-grade fever, which was not documented, but no other systemic manifestations. She had come in with a CT, and after the CT, she was started on anti-edema measures, and then the MRI was done. So I think we can show the CT. Yeah.
Yeah. So this is the, I think we are a non-contrast CT. This is taken from the video, so apologies for the slightly blurred images. But you can appreciate there is edematous changes in the bilateral mid and posterior cerebral hemispheres with some nodular hyperdensities, hyperdense lesions along the right parietal lobe, along the falx, causing compression on the posterior aspect of the corpus callosum and also the lateral ventricles. Again, edematous changes extending up to the temporal lobes and the occipital lobes on the right side. Contrast wasn't there on the CT scan, so we'll go ahead with the MR. Again, MR, you can corroborate the findings on the CT. Again, bilateral edematous changes with these multiple conglomerated tiny nodular hypointensities or isointensities on the T280 sequences. Some areas of mineralization on the T280 sequences demonstrated as hypointense changes over there, with corresponding signal abnormalities on the SWI sequences. So punctate foci in the right occipital, parietal, and parietal lobes. The nodular abnormalities do not demonstrate any restricted diffusion, not very significant. Some areas of low ADC along the cortex, but the foci itself, I don't think demonstrate any restricted diffusion there. Post contrast, you have this cortical leptomeningeal and nodular enhancement, predominantly in the right parietal occipital regions along the midline, the paramedian regions, going up to the pericallosal areas on the mid and posterior segments, along the mid and posterior segments. And on the spectroscopy, I have only one single focus along the right posterior periventricular lesion, which demonstrates the significantly elevated choline peak. The creatininases are reduced. There is a lipid peak, but not very significant. Yeah, other than that, no diagnostic peaks. Some macromolecular peaks around the 0.9 to 1.1 millimeters. Chest X-ray was done, cannot appreciate any nodular opacities or consolidated areas, possibly some areas over there in the right lower lobe, but are not significant. This is like these punctate hyperintensities are likely external than internal because they extend along the abdomen too. Differences we thought of if you exclude the spectroscopy findings based on the imaging and the clinical presentation. Tuberculosis of a conglomerated pattern was thought of as a possible differential, given the similar imaging pattern with hypointense changes on the T280 sequences with mineralization and these areas of abnormal enhancement. Other differentials which was thought of was fungal etiology, given that the signal changes on the SWS sequences, and neoplasm and infiltrating neoplasm such as lymphoma, possibly involving the corpus callosum, was also thought of. Dr. Padma, next.
So on the investigation, she had a normal counts, normal ESR, sputum. She was worked up for systemic signs of tuberculosis. Her sputum AFB gene expert was normal. Her immunodeficiency workup was normal. And in view of the differential workup of fungal workup was done, which was negative. Her MANTO was given, although she was a 17-year-old girl, plus 15 mm. And we had, so our questions was, one was following the CT, how could we have thought of diagnosis of granulomatous disease, because the differential mainly thought of at that point was a tumor. And second thing is, after the MRI, how confidently could we have said that it was tuberculosis, because later on the biopsy came as positive and gene expert was positive. So could we have withheld the biopsy and thought of only tuberculosis at that point of time was our thoughts.
But that's an easy question to answer now, isn't it?
Yeah, it is easy to answer now, but retrospectively considering the size of the lesion, it was extending to the contralateral side and the mass effect, it was a very difficult decision to make. So
true.
Especially with a very enthusiastic neurosurgeon who wanted to take the entire lesion out. So
oh my God.
it was a difficult decision. So,
but if we call this a neoplasm, I don't know which neoplasm we would have called this. let's start the discussion there.
Yeah, and I don't know, but there were some differentials from the neurosurgical side of.
Nihaal will agree that the process is still very surface of the brain related to edema around it, right?
It doesn't look like a single lesion though, and
Yeah,
multiple
exactly.
lesions are there.
Exactly.
So it's not a single lesions to call it a neoplasm, other than the spectroscopy findings, which can be.
But even if we said
inflammatory findings,
yeah, the closest neoplastic process here would be disseminated leptomeningeal high-grade medulloblastoma kind of tumor. Now, if you have that, then the diffusion would have been more strong. Yeah. And you also would not expect so much white matter edema along with that process.
Yeah.
Then the other differential you might want to consider is a high-grade glioma, but there is no glioma here. There is no mass as such sitting in there. So it would be very unusual to call this a tumor in the first instance. But it is tumefactive, but that's a different word.
So,
Dr. Atin? Yeah.
In our experience also, we've seen a lot of tuberculomas which are appearing this hyperdense on plain CT. So whenever we see conglomerate lesions, or maybe not even conglomerate, lesions like this, which are hyperdense on the plain CT, in our practice, we do keep tuberculomas as one of the top differentials in the list. And many of them would be hyper intense on plain T1 also, actually, at least iso intense or mildly hyper intense on the plain T1 images. In the same areas, you said right, they are appearing slightly hyper intense on T2. I agree with Fish. It's easier to comment now rather than seeing it prospectively, but I do believe with your differentials, tuberculoma or otherwise fungal are the first two possibilities which we would also consider based on the imaging itself.
A CT chest would be useful.
CT chest had shown a nodule which was reported, although we don't have the films reported by our radiologists. But even then, the differential was a fungal. So my question was, clinically, should we start on ATT and then wait, or just directly go ahead, do the biopsy as was done in this case? So that was the initial thought process.
The case actually looks pretty similar to the textbook case there. So yeah, retrospectively easier to say than at the time. But yeah, tuberculosis would have been the primary differential there.
Was a gene expert done on the biopsy specimen?
Yeah.
Yes, it was done on the biopsy. The sputum was negative. Sputum gene expert was negative. So the biopsy sample was positive.
I see. Okay.
Any history of any family history?
No family history of contact. There were no other systemic signs. She was a very well-built, well-preserved child. So she was too well to think of. And it was an instant going over the last 3 months. She had a headache for which she was not evaluated, but there were definitely signs to suggest that it was a significant headache.
So is your question is whether you could have avoided the biopsy?
No, my question was, could we have sure with how much confidence we could have said initially it was a tuberculoma? That was my question.
It's difficult.
And not fungal or something else.
Yeah, it's very difficult, I think.
And actually, Dr. Nihaal had said tuberculoma right from the initial shot. So what was his, so how did he arrive at that? What were the imaging features that he had considered? So that was my...
Yeah, just like Dr. Atin pointed out, the T2 and the changes on the conventional images, the edema, the lack of a lesion on the, a solitary lesion on the post-contrast, and also something which helpful was you did not share the spectroscopy with me. So I did not see the spectroscopy, but the T2 hyperintense changes, as Dr. Atin also said, the T1 iso to slightly hyperintense changes, they reminded me of a tuberculoma, or multiple tubercular etiology kind of spectrum.
I think Kiran has made a very valid point about spectroscopy usage here and how much of pitfall there exists. But in the UK, for instance, if we saw this, I would have given the fungal infection as a differential here because of those susceptibility weighted changes you have as well, because we see that more common. But then for fungus, the child would have been immunocompromised in some way.
Yeah.
So our radiologist had given a fungal higher up than tuberculoma. So
Yeah, those are the two differentials. So yeah, it's fair enough, I guess.
Yeah, thank you.
All right. Thank you. Yeah, Dr. Vivek.
Yeah. So this is a 5-year-old female child who had a background of intellectual disability with autism, with normal gait, and no other. So family hasn't shown the child to any neurologist. Because it was mild intellectual disability and autism was not that evident to them. But just recently, she got admitted with us in hepatic encephalopathy because of due to hepatitis A. And she had decerebrate posturing. She was ventilated, so raised intracranial pressure. And after a few days of ventilation, she was extubated. Just for a day, she looked better with much better sensorium, interacting with parents, though still mute. And the day later, she deteriorated again, more so by no recognition of family, dyskinetic, even though the liver function and the coagulation was rapidly improving. So then in that situation, we thought of a para-infectious process. Dengue was negative, as was scrub. So seasonal illnesses were negative. She did have a sodium of 146 at admission, and it rose to 166 in 36 hours, 20 millimoles increase. So then we have these MRI images, which are difficult to explain just by hepatitis A associated hepatic encephalopathy. And we also need to keep in mind that she had a background of developmental delay and autism, mild autism, with normal hearing.
Yeah. So some degree of volume loss in the supratentorial brain. Again, symmetrical edematous changes in the bilateral thalami. The inferior cerebellar hemispheres demonstrate dysplasia on both sides, better demonstrated on the coronal images too. The brainstem is also hypoplastic. The pons is hypoplastic, slightly abnormal corpus callosum, but not very dysgenetic or hypogenetic. So the primary changes are brainstem hypoplasia, dysplasia of the inferior cerebellar hemispheres, and edematous changes along the bilateral thalami on the T2 weighted sequences. The cerebral peduncles also along the substantia nigra demonstrate some hyperintense changes. On the diffusion weighted sequences, you can appreciate the additional changes of restricted diffusion along the superficial and the deep white matter on both sides. They're rather symmetrical. The thalamic changes also demonstrate these areas of cytotoxic edematous changes. The cortex also appears slightly hyperintense with some low areas on the ADC signals. So probably there is some particular cytotoxic abnormality in the bilateral cerebral hemispheres. Cerebellum also looks slightly bright on the diffusion weighted sequences and slightly low on the ADC sequences. So primary abnormalities in the central regions of the brain with the involvement of the white matter and possibly of the cortical regions of the bilateral cerebral hemispheres and the cerebellum. The question was, Dr. Vivek, is it ANE or is it hyperammonemic encephalopathy or hepatic encephalopathy? Sodium levels were also high, up to 168, with an increase of 20 millimoles in around 36 hours. So could that be a cause, like a hyponatremia related brain changes? Hyperammonemia can present, or hepatic encephalopathy can present with bilateral thalamic changes and particular involvement of the cerebral hemispheres. Paul-G again can present with bilateral thalamic changes and cortical abnormalities. These are differential on imaging. I don't think this child was on vigabatrin, but vigabatrin also can present with cytotoxic brain injury of the central structures of the brain. I'm not sure if aspirin was given, but Ray syndrome also in a background of liver dysfunction can present with bilateral thalamic changes and peripheral regions of the brain can be edematous. Hypernatremia is a question. I haven't put up the images, but they usually involve the pyramidal tracts of the brain and the lobus pallidi and the central tegmental tracts of the brainstem. The thalamic involvement is slightly atypical for hypernatremia. So these are differentials on the imaging, and I'll open the case for the panelists to comment upon.
The best fit is the ammonia itself, right? But of course, the background genetic problem of the brain, the cerebellum is so badly disfoliated and all that. But everything else can be explained by the acute problem, isn't it? Did you say the ammonia was based?
Yeah, ammonia was
350.
Yeah.
350, yeah. Or more than 500, yeah.
But then you have raised Polgy as a possibility, and in the context of hepatic encephalopathy, that might be relevant. I don't know how much in Alpers would you get all these cerebellar disfoliations and all that, though, and structural.
No, I think that's that's a separate. I think that's more of a not related to the acute or subacute event. I don't think the child had epilepsy, though, Dr. Vivek.
No epilepsy.
Yes. So yeah, hyperammonemic or hepatic encephalopathy would be differential on the acute or subacute findings. And a genetic analysis for the posterior fossa abnormalities.
Okay, thank you. NMD was also negative. I forgot to mention. Just did that.
Okay.
Because of this kind.
Yeah. Got it. All right. I think we have one more case. Dr. Juhi.
Hello, am I audible?
Sorry, Dr. G, just before we go to the next case, the questions of A&E by Dr. Habib and Dr. Sunil. At least on the imaging, we haven't got the typical findings of A&E, but do you agree, Dr. Mankad, or still go with the
acute necrotizing encephalo. I mean,
Yeah.
if you look at the thalamic changes, you can think about that. Then there are the additional areas of white matter. The cerebellar is also involved, I think. So it is a differential diagnosis here, but the context of a child with such a high, that would be very relevant, right?
Yeah.
And ANEC, I think, remains a differential. I would completely support that. Question is, how do we exclude it in this case? And Sunil's question is quite relevant, the whole relationship with the liver dysfunction as well.
It was hepatitis A.
Okay.
But I have a question for you, Vivek. Are you going to look further into the background problems of this child with that cerebellum looking like that? If you come to find anything, let us know, please.
Sure.
Yeah. All right. Thank you. Yeah, Dr. G, sorry.
Good evening, everyone. So this was a 2-year-old previously developmentally normal child, and she presented in August this year. So she had a short febrile illness for 4 days, for which she was admitted and she was treated like a UTI outside. After the discharge, parents noted that she is not speaking as much, not playing that much. So there was some sort of encephalopathy, reduced speech, right hemiparesis, along with a movement disorder. There was right-sided dystonia. So then she underwent the MRI, which is there, and because based on the, okay, so we can see the MRI first, maybe.
Yeah, okay, sorry. So MRI, we have cytotoxic edematous changes in the bilateral basal ganglia, slightly asymmetrical. The left is more confluently involved than the right. Posterior putamen is slightly spared. Some areas of hyperintensity on the cortical regions of the frontal lobes of the cingulate cortex. Bilateral cerebral peduncles also demonstrate edematous changes, central tegmental tracts, and also some degrees of the cortical subcortical regions of the right temporal lobe. And on the flare and the T280 sequences, again, subcortical cortical edematous changes along the anterior cingulate region on both sides. Bilateral hyperintensities of the basal ganglia, left more than the right, also involving the external capsules. Again, similar changes on the T280 sequences. The brainstem also has some edematous changes over there, and the right temporal lobe cortex also is edematous. There's some reduction of the corpus callosum, mild inferior hyperplasia. I'm not sure of the signal changes on the cervical cord. We don't have an axle over there, but it looks slightly hyperintense. There's no corresponding changes on the SWA sequences. So yeah, Dr. Joy. Dr. Joy, are there?
Yeah, so the clinico-radiological possibilities were infectious, para-infectious. Second was neurometabolic, and including mitochondrial, then biotin thiamine basal ganglia disease, and autoimmune encephalitis. So the various viruses, including EBV, JE, and the rest of the viral panel, which is commonly done, was negative. West Nile was also done, which was negative. And CSF had 4 cells protein of 10 and the sugar was around 51. So the CSF was also normal. Then for BT PGD suspicion, she was started on biotin and thiamine, and genetics was planned. And for metabolic, the TMS, GCMS sent during the acute stage came out to be negative. And for autoimmune possibility, she underwent only NMDA, which was negative, not the rest of the detailed panel. And she was given a methylprednisolone pulse followed by oral steroid taper. So now she is post 12 weeks of illness. She has improved significantly, but still has a residual hemiparesis and a movement disorder. So my question is that she hasn't still underwent a complete autoimmune panel, and also genetics is pending. So genetics I have sent, and for autoimmune I'll need to do a CSF again. So how relevant will be sending that workup in this case?
At least the imaging findings, they have got most of the differentials over there. Whatever you mentioned, that is what we think of on the imaging. The demyelination, as Dr. Sunil has mentioned, is a possibility.
MOG and NMO were done, so they were negative.
Okay.
So my question is that how relevant would be the detailed autoimmune panel, because that is something that is pending. We don't have a detailed MRI spine for her.
Yeah.
I think it would be useful to do a detailed autoimmune panel on the sample which you've taken before you gave the steroids.
So what do you mean by a detailed autoimmune panel? What does that mean?
I mean, only the NMDA was done.
So what do you think is other detailed one, with this basal ganglia change which can come, because everything else presents with epilepsy, because that panel is more for adults. When in children, the panel really CSF, NMDA, MOG, NMO are the ones. Rest all GABA, A, B, VGK, everything presents with status epilepticus, more of an adult. So is that what you mean? Adult, the detailed panel? What do you mean?
What I mean is for anti-DR2, so that will not happen.
That is not available.
So yeah, and in literature I was searching, so this was reported with VGKC as well, as you mentioned, but again there were no seizures. So and the rest of it are not as relevant. So yeah.
Yeah, so autoimmune, whatever is relevant for a child with basal ganglia involvement, which is available, has been done, right? So we won't be able to, because DR2 is only available in Australia, and that also people are not sure if that entity exists or not, or is because it always only came from Australia, those antibodies. So, so there is not much help you will get by subjecting child to CSF again, right?
Okay. All right.
But do check because I was looking Nihaal's slide EBV, just check if EBV was positive, even though it's mentioned negative, but because I did see this child as well. I might be wrong, whether VC IgM was positive in this child, I thought it was, but if it is negative, obviously go ahead further. If it is positive, maybe we can stop here.
VCA IgM was negative in blood.
Negative? Okay.
Yes. I think recently the child has underwent, I think today, a follow-up MR post 3 months. So I think they've reported some bilateral putaminal gliotic changes. Maybe next time I'll try to share that scan as well.
Yeah, the gliosis wouldn't be expected even if it's acquired or inherited. So striatal necrosis is normal consequence of
Right.
Okay.
This somehow looks like a one-time insult, and we do have these basal ganglia changes often in patients, and we still do not have a single virus. There must be some viruses. We cannot check for West Nile, which can be one. So maybe some virus. But I agree, Jui, because it's difficult, because one always thinks whether we are losing out on an underlying genetic disorder, which is presenting like this. Yeah.
Send me genetics, so I'll update about the results.
Sure.
Okay. All right.
Thank
you, Dr. Jui. All right. Yeah, thanks everyone. And that's the last case. We'll meet again on the 25th of November. Kindly submit your cases by 23rd to either me or Geeta.